Hello and very welcome in this room. I'm happy to have you here. My name is Kristin and I'm going to be the moderation of this panel today. Welcome in this room, also welcome on YouTube. Thank you for joining us today. Each year, almost half of all pregnancies, about 120 million, are unintended. With women and girls in facing crisis situations being particularly vulnerable to this situation, and although there are measures available, they are rarely implemented. This is also due to abortion care being often shrouded in silence, which inhibits productive and evidence-based discussion on this topic. So this is also why today we want to put some light on this topic and to come into an evidence-based and productive discussion. So welcome to our panel, Safe Abortion, a Denied Life-Saving Intervention. I like to introduce our panel today. And I'm happy to have you all here. It's Dr. Lucía Berro Pizzarossa from Women Help Women. Feel free to welcome our panel as well. Then we have Dr. Bela Ganatra from the World Health Organization, head of the Unit Preventing Unsafe Abortion, Department of Sexual and Reproductive Health. Very welcome. And we have Najat Lahmidi, the Médecins du Monde France, who's a midwife and SHRH technical advisor. Very welcome. We do as well have with us Bill Powell. And the question is he already there? Because Bill is joining us from North Carolina, US. And it's, first of all, 5 o'clock in the morning for him. And second of all, as you all know, hybrid setups are always a little fragile, or sometimes. So he will join us probably later. And yes, talking about safe abortion, we would first like to set the scope. So if we talk about safe, Bill, very welcome. Let me shortly introduce you as well. Bill is a senior medical scientist for the IPAS Impact Network. So happy to have you here as well. And yeah, thank you a lot for getting up so early for us. So we would like to first set the scope. If we're talking about safe abortion, what are we actually talking about? And I'm very happy that Bela, you can give us a short introduction on this topic. Oh, do you have a mic? They should be already working.
Okay, so to pick up on, can you hear me? Yeah. To pick up on where she started off, every year globally, there are at least 121 million unintended pregnancies. 60% of these end in an abortion. All right, I'm going to figure out how this works.
Technical support is coming.
But the problem is not that they end in the abortion. The problem is that over half of them do not happen in safe circumstances. And 1 in 3 happen in the most dangerous or risky situations where people are using traditional medicines, inserting dangerous things into themselves. And it is these most unsafe methods that carry a big risk of complications and potentially death. We know that globally, unsafe abortion causes between 8 to 13% of all maternal deaths. But we know that in humanitarian contexts, data is limited, but we think, and some anecdotal evidence suggests, that up to 50% of maternal deaths can be caused by unsafe abortion. The tragedy of all of this is that in order to reverse the situation, the solutions are scientifically extremely simple. This is, of course, a context that you know, that the challenges in the humanitarian context are manifold. Unintended pregnancies also go up because of the lack of contraception. There is a huge amount of sexual violence. We know that systems are disrupted, but also importantly, even when responses are considering maternal health, sexual health, reproductive health, safe abortion is deprioritized because it's stigmatized, because people are worried that it might be illegal, and people are also concerned of whether it's easy enough to do. But I'm here to show you the evidence on how it is possible. WHO has, for the last 20 years, been bringing out recommendations, evidence-based recommendations, on how safe abortion care can be provided. For us at WHO, it is a health service, just like any other health service. It's a time-sensitive service because obviously if women are pregnant and they do not want to be, they need to get services quickly. And we are recognizing it as one of the essential package of services of sexual reproductive health that need to be part of a humanitarian response. So essentially, there are two different ways in which safe abortion can be safely provided. One is through the use of a simple outpatient procedure, which can be provided at any context where you're setting up to provide basic emergency obstetric care. But also, it can be provided through tablets. There are two types of ways you can do this, either by using a combination of two tablets, mifepristone and misoprostol, or using the other one, which is misoprostol alone, which is often the more easily accessible and available medication. So our WHO guidelines speak to the different ways in which the services for both these types of methods can be provided. And we don't need to go into the details of this, except that if you can see in this sort of rainbow circling the woman who needs this care, we have a number of options of where, who, and how these services can be provided, in the sense that evidence is there for a number of different approaches to service delivery that can be adopted to the context you're in, to the resources that you have, and to the situation in which you are operating. So that's why it's immensely possible for this to be an essential part of your service within the humanitarian context. And particularly when we're talking about the provision of abortion through the use of pills. What this slide is sort of showing you is how our evidence on what we know about how these pills can be provided has progressed over the last 20 or 25 years. When these pills first were introduced in the 1980s, we talked about a central hospitalized-based service provided in tertiary care, provided only by OBGYN providers. As practical experience and evidence grew, progressively, we have been able to talk about this as a decentralized service, moving down to primary levels of care, and in fact now to be talked about as something that does not even, in the earlier stages of pregnancy, need to be in a facility at all. Similarly, from an era when it was only OBGYN specialists who could provide this service, evidence has grown that more and more cadres of providers, and now we can actually speak to the evidence that individuals themselves can manage the process outside of a facility and outside of a direct supervision of a provider. And that means that, and it's not a surprise, that women can assess whether what their gestational age might be. Women can then take the medicines, manage the process, and decide for themselves whether the abortion has been successful or not. So the challenges are not in the ability of women to be able to do this. Our challenges lie in making the support system that they need in order to make this happen. Most importantly, having the right information about the medicines. And do remember, these are extremely safe drugs. And when taken properly, mortality and morbidity from safe abortion is negligible. But yet, you need the information on how to take these medications. And most importantly, you need the commodities and access to the commodities. And so, I think as we move forward in the panel, we're going to hear from others who have actually tried to take the steps to see how to make this a practical reality.
Thank you so much, Bela. So, yes, please. So, as you said, the challenges are not the scientific solutions, but it's the support system. And yeah, we're also very happy to have you here, who can bring us some more experiences from the practical, operational side. And I'd like to start with you, Najat. So, hearing what Bela had said, how does safe abortion actually look in practice?
I'm strongly believe on the power of testimony. So let me begin to answer your question with this story we had a profound effect on me. It's about Mara. Mara, she's 13. She lives in the country, one of the most restrictive regarding abortion. In a humanitarian context, I will not mention the context to protect our team. Nathalie, she is midwife for Médecins du Monde, visits Mara village as part of mobile clinic. Mara, she has been raped. She is 6 weeks pregnant and wants an abortion. Nathalie, like probably many of us, is committed to the right to abortion. However, regarding the legal framework, she does not wish to provide these services. So she refers her to another colleague, and she gives her an appointment in 1 week's time to the next mobile clinic visit. 2 days later, Mara calls Nathalie. Nathalie immediately understands that she performed an unsafe abortion. Her emergency transfer is scheduled, but unfortunately, we learn her death 2 hours later. My name is Najat Lahmidi. So one of my mandates is to support the team on the field to implement abortion care. It's important to precise that we don't have in Médecins du Monde an hard clinic. We mostly work with the National Health System, with the MOH, Minister of Health. Neither in humanitarian context. Médecins du Monde has been committing in abortion rights for almost 15 years. We started by joining movements and strengthening our advocacy on abortion rights. This helped to change norms and legislation. Some projects provided abortion services, but is still on the margin. In 2022, WHO guideline on abortion created a paradigm shift. 3 months later, the US Supreme Court overturned the federal right to abortion. Faced with this shockwave, Médecins du Monde decided to change the way we approach this issue. as Médecins du Monde, as a medical NGO, we have to go further our advocacy. Abortion care is intel of healthcare. We have to provide in all your projects. So to do this, we are written down our 8 commitments. 2 commitments on value. Abortion is human right. Abortion is essential healthcare. And 6 more commitments. Operational commitments is like the basic conditions to implement, such as recruitment, supply, training, support our staff, and also, and of course, their protection. Concerning the intervention, there are many forms. But as a minimum, and for the time being, all projects must to provide information of safe-managed abortion, which represent a huge opportunity for actions. Dr. Lucía will give us some feedback on this. But to give you just 2 examples, in other contexts, we directly train traditional midwives, who are often the people clearly identified as performing unsafe abortion. In other contexts, we work directly training safe-managed abortion to the community worker. Thank you.
Thank you, Najat, for this insight. We do have another insight from a voice that can't be here with us today, but we would also like to share. It's, thank you. So we're going to have a short video and also a short report from Dr. Liberat Nijoyandika from Médecins du Monde RDC, who's the medical coordinator there. And I'd like to share this one with you.
Bonjour, je m'appelle Libera, le coordinateur médical Médecins du Monde RDC. Alors je voulais juste donner 1 ou 2 exemples par rapport à l'accès aux soins d'avortement sécurisé. Deuxième exemple, c'est l'exemple lié en fait aux procédures et tout ce qui devrait être fait. Là, c'était dans le Tanganyika. Dans le Tanganyika, on a eu une femme qui tout simplement est venue pour nous proposer, pour nous demander si on pouvait l'aider. C'était aussi une jeune femme autour de 25 ans, mais qui vivait chez ses parents. Et elle avait peur. Elle avait peur parce que elle était... généralement, c'est les femmes en fait qui ont été violées ou soit par les membres de la famille. Mais de toutes les façons, leur histoire est un peu semblable. Alors du coup, elle est venue au niveau du centre de santé. Et nous, comme on n'avait pas encore commencé ce programme au niveau de Tanganyika, on a commencé à discuter avec les équipes. On leur a donné un rendez-vous de revenir la semaine prochaine pour avoir beaucoup plus d'informations. Nous, on en a discuté avec les équipes. On a fait des discussions qui ont duré plus de 4 semaines. Finalement, au final, la femme, en fait, on l'a perdue. On l'a perdue, elle n'a jamais eu accès à ses soins. Et ça personnellement, ça m'a beaucoup touché parce que je me suis demandé en fait si elle a un problème après, si elle essaye de le faire dans des situations d'une manière clandestine et si elle perd sa vie, est-ce qu'on n'est pas vraiment coupable? Et ça m'a personnellement boosté en fait pour discuter avec nos équipes et pour commencer à le faire. On peut ne pas être prêt, on peut ne pas savoir tout, comment le faire, mais après, quand on a commencé à le faire, et progressivement, avec bien sûr l'accompagnement de nos référents au siège, on a pris en charge des cas qui ont eu finalement accès aux soins d'avortement sécurisés. Merci.
So, coming back to our panel and coming back to you, Bill, and we can't see you now, but maybe in a moment. There you are, great. So, Bill, at IPAS, you're, coming from IPAS, you're bringing more the scientific part, view on this topic. hearing what you heard so far from Najat, also from Bela. So where, from your perspective, like where are we now talking about safe abortion in operations?
Sure. Good morning, and I'm just checking if you can hear me okay. I actually can't see the YouTube stream, so I'm just making sure you can hear me and see me.
Yes, we can hear you very well. Thank you.
Okay, thank you. And just to note, I am based in North Carolina with IPAS, but this morning I'm coming to you from New York City, where I'm at another meeting. And of all places, there's an internet outage in my hotel. And so I'm streaming on my phone, and we're trying to put it together technically that way. And I'm sorry I can't be with you there in person. But anyone not familiar with IPAS, we're an international NGO that began in 1973 around the development of the manual vacuum aspirator for uterine evacuation, and then the provision of it to health systems in many countries. And over the last 50 plus years, our singular commitment to expanding access to abortion has remained constant. It's all that we work on. We provide technical assistance, conduct research, and advocate for safe abortion globally. And I thought it would be helpful just to give a brief history around safe abortion in humanitarian settings. I'm assuming my slides are showing because, again, I can't see. But this timeline you see represents just some important points along the last number of years around safe abortion. Going back to 2010, essentially nothing was happening with safe abortion in humanitarian settings. And even post-abortion care, or PAC, was often stigmatized and even sidelined in some settings. By 2015, diversified funding enabled the launch of the Safe Abortion Care Sub-Working Group, or the Interagency Working Group on Reproductive Health and Crisis, better known as the IWAG. And that allowed us, of course, to work directly on safe abortion, talk about it publicly, et cetera, with this diversified funding. And we did an assessment within the organizations affiliated with the IWAG to find out about how they were moving on safe abortion and challenges and steps. And from that, we developed a very helpful guidance called the 10 steps for starting or expanding SAC programming. And I'll discuss that more in a few minutes. 2017, an important development was that safe abortion care as menstrual regulation, as it's called in Bangladesh, was implemented systematically as part of an early response for the Rohingya refugees in Cox's Bazar in Bangladesh. So it was the first time actually that safe abortion had been implemented in, systematically throughout a response and in the early days, which really helped dispel the myths that there was no need, the myth that there's no need, there's no demand, couldn't be implemented in a crisis, but in fact it was done successfully. And there's several publications on that you might find interesting. An important milestone in 2018 was in the revision of the Interagency Field Manual and the associated MISP, the Minimum Initial Service Package. We were able to get safe abortion care included into the MISP in two ways. One, as part of the important package that should be offered for survivors of sexual violence, and then also as an additional priority to be offered in the earliest days of an emergency to the full extent of the law. And now we find ourselves in this time period with these advances and some momentum. But I think there's risk, actually, from a lack of dedicated funding to sustain and expand the successes. So that is certainly one challenge, perhaps we're in at the moment. And additionally, you've already heard Bela speak about self-management of abortion, but this is also seen as a promising approach to increasing access, and we'll discuss that a bit more later. If you could go to the next slide, please. Actually, slide number 3, which has some data on it. I've already heard some discussion around abortion mortality and the estimates for that globally. And again, these are estimates because abortion is under-researched, hard to research, particularly mortality. But let me offer you some new evidence about maternal morbidity in humanitarian settings, and that's those numbers on the bottom of the slide, 1.6 and 7. We have some new evidence about this coming from humanitarian settings because IPAS has been working with the Guttmacher Institute and MSF for the past several years to look at morbidity as a sort of proxy for maternal mortality in humanitarian settings. We use the WHO methodology to review the symptoms of people coming in to seek a post-abortion care in 2 conflict-affected settings in Africa, one in the Central African Republic and one in northern Nigeria. And the data from our study indicate much higher frequencies of severe complications when compared to other hospitals in a WHO study conducted in stable settings across Africa. Near miss events, that is those complications in which the woman almost died but didn't because of intervention. So those events were 1.6 times more frequent. And then potentially life-threatening complications, another set of defined abortion-related complications, were almost 7 times more frequent in the 2 hospitals in our settings than compared to those in the WHO study in stable settings. So important new evidence around morbidity, and certainly something we can't extrapolate everywhere, but it gives us some clues of the magnitude of morbidity in these settings. And then slide number 4, earlier I mentioned the 10 steps document you now hopefully see on the right of the screen. It takes organizational change for agencies to begin to offer safe abortion or strengthen what they're doing. And the steps you hopefully can see on the right, I know they're small, but the steps we found when talking to a variety of implementing agencies that they thought were key to starting or advancing abortion programming included things like simply having frank discussions, developing and disseminating a policy, conducting values clarification activities with staff at all levels, not just the clinicians, but management, headquarters, etc. Understanding and analyzing legal context, because the law is one thing and the legal risk is something different. And so, there's different contexts to understand, and how we can work there different depending on policies. And finally, kind of the last step is actually building clinical and management capacity. So a lot of work has to go on for organizational change. And at IPAS, we believe part of our role is to encourage and enhance and advance the humanitarian field around safe abortion. And here on the left of the screen, you see several examples of our partnerships with important humanitarian practitioner and strategic organizations with whom we've engaged to support organizational change around safe abortion. I'll stop there and back to you, Kristin.
Thank you. So I think following your input, the need for safe abortion has become quite clear, and also good to see that, such as the guidelines, the 10 steps are already available. We'll come back to the question of what we actually need to do and what is going to be our next steps, also like talking about you as the audience here, what can we do to move forward. But first of all, let me please also give the voice to you, Lucía. You're working in the context of the Ukrainian war. Can you also give us some input on the experience you make there?
Hi, can you hear me? Excellent. Thank you so much for the question. I think what I wanted to share with you today, and I'm sorry for my slides, those were not the fonts that I chose, but something happened. My name is Lucía. I am a researcher and an abortion activist. I have been working in the field of self-managed abortion for a long time, and I work with an organization called Women Help Women, which is an organization that runs a telehealth service that works in, at this point, we work in 9 different languages. We work 24/7, and we cover around 30 countries with the telehealth service, but also more countries with the partnerships that we have with people on the ground. So we had been working for a long time in Poland, and when the war in Ukraine started, or like heightened, then we decided to, expand a little bit. So that's what we want to share with you today, is a little bit of like our experience supporting people to self-manage abortion in the humanitarian context of Ukraine. So I call this firefighting because we don't deal with literal flames, but I wanted to share like how it feels to have mobilized self-managed abortion in a time of crisis. So we know, and I think Bela all of you have done a fantastic job in like highlighting how the crisis disproportionately affect certain communities, women and girls, people that have the capacity to get pregnant, and as such they demand like clear and urgent action. And it's in these moments that organizations like the one that I'm a part of, but also our sister organizations, are able to give on the ground support. So we know that the Ukraine war is not just a geopolitical conflict, it's a reproductive healthcare conflict. It disrupts everything, and for people that can get pregnant, that disruption often means losing access to essential healthcare, because when war hits, and this is nothing new to you, obviously, but like services collapse, access to contraception, prenatal care, safe childbirth, and abortion services become even more limited. And we saw this clearly in Ukraine. The war didn't just bring bombs, displacement, it also revealed a deep crack in the reproductive health systems. Because once again, women and girls and people that have the capacity to get pregnant are the most marginalized in this crisis. And I wanted to highlight this because just as the COVID-19 pandemic exposed a series of inequalities, the war in Ukraine exposed these profound failures of the Polish state in providing abortion services. So when women and girls and people that can get pregnant were arriving in Poland, they found a pretty dire situation in terms of the legal system in Poland, right? We know that in 2020, the Constitutional Court of Poland basically imposed a de facto ban on abortion, right? Making it virtually impossible to access a safe abortion in the country. So we know that what the WHO tells us about abortion and how it should be provided and the quality of the services that should be provided, yet for countries like Poland that continue to enforce restrictive laws, the access remains a difficulty. And for Ukrainian refugees in particular, the barriers became even more burdensome because there was a language barrier, there was very incorrect expectations about access to abortion in Poland that, as I said, has a de facto ban. There was very little understanding of the very complex Polish legal system about abortion, and of course, because it's a humanitarian context, there was abortion is generally stigmatized, but because organizations fear that they will lose funding if they provide abortion services because the political reasons, etc., there's very few organizations that actually provide abortion care in these circumstances. So here I just wanted to show you, because it is estimated that 120,000 abortions or 250,000 abortions happen in Poland, and of those, only like 107 are provided by the Polish state. Right? In the face of these like very harsh realities, it is networks like mine, like ours, the ones that are giving responses to this. So what did we do? We organized pretty quickly to respond to these challenges. Yes, we acted swiftly and decisively. Within weeks, we reorganized all of our efforts that were directed to serve the population in Poland, to also include refugees coming from Ukraine they were in desperate need of support. So this meant that in constant communication with the people, with the community affected, to understand what they needed and the most optimal way to work with them, right? Setting up systems of accompaniment. And we call it accompaniment because it's not a vertical service provision model. This is like shoulder to shoulder, person to person, peer to peer. So we moved a lot of our funding that, I just want to say that we're a 24 people organization. Only 3 of us have, only 3 of the team has full-time jobs, and just for you to get an understanding of what the team is composed. But yeah, we allocated funding, and with the support of donors and partner organizations, we were able to respond rapidly. We translated everything into Ukrainian. I don't know if you can see that's our website. It's supposed to work as a little video, but it doesn't. But you can see that all of our website is now available in Ukrainian as it is in Spanish, English, Portuguese, Italian, etc., many other countries, because obviously we have to meet people where they are, right? To speak to them in the language that they know and they feel comfortable with. And we ensure that all of the services that were provided to them were for free. And we hired Ukrainian people to support people in trajectories to self-managed abortion. So they would have advice 24/7. They could contact us. As I said, we run a telehealth service for more than 10 years in many different countries, so this was not new to us. The only added issue was the issue that these people were coming from our workplace. So we didn't, this is a little bit of like the social media dissemination that we did in order to let people know that these services were being made available to them. And then we didn't stop there. So we knew that the crisis required collective action and that the reproductive rights movement thrives in collaboration, including with organizations like yours. But through the Abortion Without Borders network, which is a network of people, of organizations in Europe taking advantage of this like very patchy landscape of abortion regulations in Europe, what it does is to support people to access safe abortion. Because we know that when people are in restricted settings, they don't stop needing abortions, right? So they start having unsafe abortions. And what we want is that every person that needs an abortion has access to a safe one. So as I said before, the Polish government did 107 abortions in 2022. Abortion Without Borders helps 123 people a day to self-manage their abortions, and 7 people every day travel around Europe to access an abortion in clinic. This is a little bit of how we work. I'm happy to share more details, but I wanted also to say that this comes at a great cost, financially, emotionally, in terms of resources. So we decided to launch a campaign to show the governments how much it costs for an organization to run and how much the work that we're doing to basically fill in the gap that they are leaving with regards not only to Polish women, but Ukrainian refugees that are entering the country. They are being made marginal, basically, and not given the services that they need. So we invoiced them, we took it to the parliament, we had a session, we put it there, stayed there for 2 hours for them to see how much it costs to civil society to be filling in the gaps of a state that has failed to provide basic services. Not only to Polish people, as I said, but for people running from war. Since 2022, we have worked relentlessly to meet the needs of those in crisis. The helplines have been essential, answering more than 500 calls from people across Ukraine and Poland, offering compassionate assistance and service. This is the Abortion Without Borders helpline. More than 1,200 packages of abortion pills have been shipped to people of Ukrainian origin in Poland, enabling people to access care despite the conflict. We have supported 150 people to travel to different parts of Europe, as I said before, because they are like further down in the pregnancy and they need a surgical abortion. And we have answered like the emails of more than 3,000 people that have contacted us throughout these 2 years. So I think these numbers reflect the immense demand for the support and the trust that people place in organizations like us during these critical moments. So I just wanted to finish by saying that the crisis has revealed more than the flaws in the reproductive healthcare system during conflict. it has also shown the power of feminist solidarity. Feminist organizing around reproductive rights has been a lifeline for so many at this point. From translating materials to navigating complex international laws, we have proven time and time again that feminist action is powerful, is agile, is responsive, and is able to work quickly and effectively in settings that other people either don't want to or can't work in. So the barriers created by the war are parts of a larger system of reproductive injustice. So yeah, I wanted to say that we are not simply putting out fires, we're building systems of care, of solidarity, of justice, systems that build from the bottom up, systems that meet people where they are, how they are, in the language that they need, at the time that they need, in the circumstances that they need it. And I just want to remind, because I think this is a great setting for us to all remember, and you have organizations that are very different also here talking about the same topic, is that it's about resistance, about solidarity, about justice, about tapping into our strength and being able to provide every person that is having to live in an environment, in a humanitarian environment, the possibility to decide when and where and how they want to have children. And yeah, we will continue to fight, to organize and to care for every person, every time, everywhere. So that's it.
Thank you, Lucía. You've shown a lot of how safe abortion can be supported, can be implemented. You talked about building systems, and you already spoke about some barriers, and this is where we want to point out next. So, what are the obstacles? What are the biggest barriers or risks to be taken into consideration if we want to implement safe abortion or access to safe abortion or self-managed abortion? And also want to lift up here your experience here. So Najat, what are your findings on that?
So, thank you. For to move the barrier, in addition to the 8 commitments, Médecins du Monde defined 7 steps to successfully implement abortion care. A key step in this process is what's known as values clarification, VCAT. This methodology, developed by IPAS, enables us to talk openly about abortion, to understand our positions and our resistance, sometimes unconscious, but that we have. Very often, after this workshop, people come to see me in one-to-one to ask me, okay, it's great, I want to do more, I want to set up the offer. What we can do? So this VCAT, this methodology, is very interesting because it enables us to find out where our resistance lies and also to start to deconstruct them and also to identify the allies we can rely on in our implementation strategy. Another step is continually exchange and be creative to finding different kinds of intervention. Another key tool is a risk analysis and mitigation matrix. As humanitarian worker, I'm certainly sure that you are familiar with this tool. But for us, it's really a key to objectify this risk. We are often make decisions based on fear and perceptions that are not necessarily real. So this tool it's a key to find the best modality for action. And to answer to your question, we realize that real risks are often low, and also that we can find the way of limiting them. You see my colleagues Bela in the video in Tanganyika. So this story. It was 2.5 past. And so we were in Tanganyika. And we have the Maputo Protocol. So the Maputo Protocol, it's an additional protocol to the African Charter on Human and People's Rights, which allows abortion under condition. And this, it was not known by the health worker. You support the team in the Tanganyika, so we have not the offer. So we organize a workshop with a local magistrate who explains the legal frameworks. And just after that, we move the barrier of the legal risk and we start to offer abortion services. I remember there are some questions of the audience to the magistrate, and one of health workers asking, okay, but how we can be sure that she has been raped? And he answered him, you are not a judge, you are not a pastor, you are only asked to give the services, that's it. It recalls also for all the health center, health worker, it's forbidden to try to convince someone to keep a pregnancy. It's a real fault, it's a professional fault, and also it's a high risk for the women. In other contexts, we set up a mysterious client. So we work with the young people, boys and girls, to identify all the pharmacies who provide abortion pills, with and without prescription. After that, we train them in a safe management abortion that they could have as a relays in their community. We work also with a small network of doctors to issue prescription. In the north of Burkina Faso, we need 2 judgment orders to provide abortion services. So we identify committed magistrates, and only with WhatsApp, we enable us to have rapid judgment orders so we can carry on the abortion in time. So all this intervention has been defined in numerous of discussion. And as we can see, depending on the context and ideas, we have many ways to intervene.
Thank you for these insights. Yes, please. So we see it is possible despite the obstacles, and we want to have also a little bit a view from a little bit more upside and have a look at the numbers. So Bill, you've been driving research on safe abortion in a refugee context in Kenya and Uganda, and we would like to have a look at your findings there.
Sure, thank you. Yeah, so again, I can't see, but we should be on my slide 5.
Yes, we are.
Okay. One major obstacle, obviously, to safe abortion in humanitarian settings is the lack of formal health services in place that provide safe abortion. An obvious challenge. And we've already discussed some of the progress and momentum around safe abortion over the last decade and heard some great examples from those on this panel of success and agency momentum. But unfortunately, this is not the norm. And I don't want you to leave with the idea that this is the type of access and opportunities most refugees and displaced people have. It is not. In most of the world, the only options available to people living in humanitarian settings are less safe and unsafe abortion methods. So one way to make abortion more accessible and safer is through self-managed abortion, which is when people manage the abortion process by themselves in whole or in part. And of course, here we're referring to self-management or medication abortion, also known as abortion with pills. And you've heard Bela early on in the opening talk about the WHO support for this. that it actually is in the abortion guidance as a recommendation. So some of the potential advantages of self-managed abortion are that there's a growing body of evidence that support the safety and effectiveness of a range of models for providing information and support, such as harm reduction programs, access through pharmacies and drug sellers, safe abortion hotlines, community distribution programs, etc. Safe self-managed abortion potentially offers greater privacy, confidentiality, and affordability. It potentially better serves the needs of individuals who face additional marginalization, such as adolescents, lesbian, gay, transgender, and people with disabilities. It can reduce the reliance on overburdened health systems, and the demedicalization of this care is likely to be appealing to those who may have been persecuted or discriminated against prior to displacement and are still building trust in their new environments. However, it's not without challenges. There are real questions around access to quality assured MA drugs, crowded housing, and a lack of privacy in humanitarian settings raise issues such as how does access to water and sanitation facilities, especially shared toilets, lack of clean water, sanitary pads or cloths, which may make managing, the products of conception and products of conception and bleeding onerous and difficult to hide, really affecting people's abortion experiences. Next slide. So in the context of these potential advantages and challenges, we partnered with the agencies you see on the screen, on slide 6, to explore the barriers and opportunities for self-managed abortion in 2 humanitarian settings, one in Uganda and the other in Kenya. This was funded by ELRA, and you can see our primary investigators, the study team, agency affiliations, etc. on the slide. Now, please note that we are still in the analysis and manuscript generating phase of this study. So all the data I'm presenting today are unpublished preliminary data with the possibility of some small shifts with final weighting and analysis, etc. So please don't quote, but we're very excited about these findings. Next slide, slide 7, shows what this study set out to understand through these objectives. Really, the first one are the experiences, that is, what are displaced women and girls confronting and accessing abortion information and care, especially regarding self-managed abortion. We wanted to explore differences. What do key differences in experience tell us about their displacement, the setting itself, or even the legal bounds of the country, host countries? We explored the community, how are community members involved in abortion info and access, and how can this involvement be strengthened and more enabling? And finally, we look at the incidence. And the final objective is, again, about the incidence of abortion in these settings using some novel modeling methods to get at that. But today, if you'll click once, we'll just have time to explore just a few findings and highlights from that first objective. Next slide. So our study context, again, I mentioned we're in Kenya and Uganda. Bidi Bidi is a large sprawling settlement in northwest Uganda, first established in 2016, and the overwhelming majority of the residents there are from South Sudan. Kakuma in northwest Kenya is a set of camps first established in 1992. The majority are from South Sudan, but there are also significant numbers from Somalia, DRC, Burundi, Ethiopia, and Sudan. And both countries have restrictive abortion laws. Next slide. So we collected data through 3 methods. In-depth interviews in which data collectors talked to abortion seekers. These 61 interviews illuminated key experiences, attitudes, and barriers that refugee abortion seekers shared with us. Secondly, there were interviewer-administered questionnaires completed using a respondent dribbling sampling method, which is sort of a modified snowball sampling, in which one seed, that's one person, gives coupons to peers who may have similar experiences in seeking abortion, and they thereby recruiting more respondents through these networks. So we achieved 1,201 people completing the questionnaire. The majority of participants in Bidi Bidi were from South Sudan. That was about 94% of that study group. And in Kakuma, 41% were from DRC, 23% from Burundi, and 22% from South Sudan, and then small percentages from other places. Most of our participants were between the ages of 19 and 35. And then finally, we also did a facility assessment of 27 facilities among the two settings to look at their abilities to provide abortion care. Next slide. So here are, again, some highlights from the results. Most participants reported that they were the primary decision makers themselves of the abortion methods they chose, the decision to have the abortion, and they performed the abortion themselves. Again, some variation there, but the majority is self-managed. And unfortunately, the great majority in both settings reported using unsafe methods for their abortions. And Bidi Bidi, again, mostly traditional herbs were used. Those were used also in Kakuma, but you see a wider range of methods there. And note, again, that only about 6% in Bidi Bidi and 24% in Kakuma reported using actual abortion medications, medications specifically intended for abortion, mifepristone and or misoprostol. Next slide. In fact, only a few of the survey respondents reported ever having even heard of medication abortion in general, and far fewer knew specifically of misoprostol. And additionally, of those reporting using medication abortion pills, most reported pill regimens and or dosages that did not align with WHO recommended regimens for medication abortion. Either the way they took the pills, the number of pills they took, et cetera. So most were apparently not using correct dosages. And the next slide. And you can see that most respondents in each site reported achieving a complete abortion, but most also reported experiencing at least one sign of potential complications, such as high fever lasting more than a day, heavy bleeding, severe lower abdominal pain, persisting the day after their procedure or process, and so on. However, only about a quarter of those with potential signs of complications the quarter did not seek follow-up care due to fear of stigma, mistreatment, or arrest, despite the great majority of facilities in both settings reporting that they offered post-abortion care, as you can see in that footnote in orange text at the bottom of the slide. And then finally, in terms of information and support, less than half in each setting reported having all the information or support that they felt they needed for this process. Next slide. So I can't report yet on the abortion incidence as being modeled from these data, but I can tell you that abortions are common in both settings. And as you've seen, the overwhelming majority are self-managed using unsafe methods, and knowledge and support are lacking. these are settings that seem ripe for interventions to reduce harm and support abortion seekers with the information and support they need to safely self-manage their abortions, as is illustrated by this slide, by this quote from the slide. But I think we have to remember that the work on self-managed abortion should occur in tandem with efforts to strengthen facility-based abortion care so that individuals can decide where, how, and what support their abortion takes, with what support their abortion takes place. Last slide, I just want to say thank you and stay tuned for forthcoming publications from this study. A couple of them were just submitted this week, so we hope to have those out soon. Thank you.
Thank you a lot, Bill. And this once again shows the urgency of a broader access to safe abortion. And we have a little time left. We also want to give, open up for the audience for some questions. But let me have one last round, and just a very quick one. So, what is it in order to give broader access for safe abortion, for self-managed abortion? What is it that now needs to be done? And maybe we can just go through this panel in this order. Lucía.
Thank you. What do we need? Well, I mean, it's a political decision, right? Like the deaths for unsafe abortion are all in their majority preventable death. And as Bela explained, and I can also share from my own experience with self-managed abortion, like abortion can be a very, very safe procedure. It can be a service that is provided like outside of a clinic, abortion with medication, or providing people with surgical abortion. But like, I want to say in also as an observation from Bill's presentation, the people that we provided access and support, out of those like 1,400 that we supported, they follow the same global numbers that we have for the general people that we serve. It's like 98% of completion and 95% of satisfaction, right? So if people are given high quality medicines and the right information on how to self-manage their abortions, they can do it. They are able to estimate the length of the pregnancy. They are able to estimate whether they need additional care. So my issue was like, let's make the political decision to support people that need abortions, and whatever to support like people's spectrum of reproductive needs, among them abortion, and also let's like demedicalize it. I think for us, one of the biggest barriers is like, oh, we don't have the clinic, we don't have the medical professionals. Well, WHO has said that is not a necessary component. Like it's great to offer people options, but like, we know that people can safely self-manage many things, including like insulin, but also their abortion. So yeah, I think it's like to make the political commitment and to tap into people's strength and working in community.
Thank you. Bela.
Yeah, I would just say that the evidence is clear, the need is there, the evidence for the solutions is clear, and there's more and more support on the normative side of integrating this into normative commitments is part of the humanitarian response. So really now the next step is for us as humanitarians to fight the stigma, to fight the fear of actually addressing this topic, to put aside our own personal views on this topic and center the fact around that there is a need that we need to address and to begin to do it.
Thank you. Najat.
In humanitarian setting, teams were trained in clinical management rape. To be honest, no one is coming in our health centers, maybe one or two people. As soon as we start to offering abortion services, survivors started coming. In Uganda, for example, we receive average 2 survivors a month. But following the introduction of abortion services, it's 50 survivors coming per month. If I return to the story of Mara and Natalie, Natalie was very upset and she was questioning herself. she came to the conclusion that it took being confronting Mara's death to really realize that abortion is indeed vital care, but also that it was an invisible reality that we didn't want to see. Before, we are not aware about situations like Mara. It makes us question, as actor, as a humanitarian actor, our vocation is to save lives. For now, Nathalie provides the services, but also she's very convinced she is saving life. Access to abortion is a matter of life and death, and this risk is increased sevenfold in crisis setting. When you are a humanitarian actor, we often don't ask ourselves whether or not to intervene. You just do it. You intervene and you respond to the needs. But concerning abortion is not the case. I repeat, all of us, when it's concerning abortion is not the case. So why? I invite us to question this paradox, why we don't accept to offer life-saving treatment. We can't avoid abortion to be realized, but we can prevent them being fatal, and all this test is avoidable. So the recommendation to the humanitarian community is the full implementation to the MIS, the Minimum Initial Services Package on SHRH. Within health cluster, the abortion case is often neglected. We need to find allies within health cluster and push the integration of abortion services within health clusters. And from my experiences, all it takes is a will, even one, to make it happen. Thank you.
Thank you, Najat. Bill, one last word to you. What is it that is now to be done?
Well, one of my easy responses is to say, here, yes, all the points that have made before me. It's life-saving care, full implementation of the MISP. That was a real win, getting it in there, and it's global guidance, and it should be followed and implemented. I also wanted to return to one point I made earlier, though, and talk about funding and, a call to donors and to, require in their donor assistance that truly comprehensive SRH care, which includes comprehensive abortion care, is a part of the package that's required from funding to recipients, so that there's the hand that feeds us that's forcing that to work. But obviously it's the person's right. It's life-saving, and it should be offered anyway. So, funding would be of great assistance, though. Thanks.
Thank you, Bill. So, yes, please. So we still have a little time of 15 minutes left, and I see already some hands in the room. Just one note also for our people, our audience that is on YouTube. You have the chance to leave us some comments, and we will try to also bring these as questions in the room. But we'll start here, the first two.
Hello. Thank you first for all of you for this critical topic. First of all, my name is Mustafa Kamla. I'm a medical doctor coming from the Kurdistan region of Iraq, and now I'm studying my master's in public health in Hamburg. So thank you again for this critical topic. It might be easy to discuss openly here, but this word could be a very sensitive subject to discuss where I'm coming from. And during my rotation as a doctor, we've seen occasional cases of women coming with serious complications of unsafe abortion or self-induced abortion. My question could be more for Dr. Bela, but others could also answer as well. So you talked about self-administration pills. First of all, they can be illegal in some parts of the world without a prescription, and they can be prescribed. And they need to be adequately educated about this, because they can also have some complications like excessive bleeding or incomplete abortions that need hospital care, but they sometimes are too afraid to go there due to stigma or due to arresting or legal complications as well. So how can these harsh cultural, legal, and religious barriers be passed on to outreach these women and to educate them? Because it's like even teaching about abortion publicly, it could be a stigma. So like if you open an office and you say that we help with safe abortion, tomorrow, like the day after, you might find a lot of people protesting and saying like this is not culturally appropriate. So how can we bypass all of this and at least to discuss and to teach these people about this and helping them to access it? Thank you.
Thank you. We would just take the second question as well.
Hi.
And then we have a first answering round. And I see you. We have the next two questions, please.
Hi, thank you very much. My question is to Lucía. I know your work from Poland. I'm from Poland too. I think it's absolutely incredible what you are doing with ADT, with Federa. So, and in this context, it's very highly politicized and highly criminalized. And I'm very curious about this aspect of criminalization of solidarity. How do you operate within the conditions of your solidarity being criminalized? How do you engage donors? How do you engage other humanitarian actors? How do you react, or maybe do you have any advocacy advices regarding the state actors? And do you see any change in your work since the government has changed? Thank you very much. And thank you very much.
Would you like to answer the questions, Bela? Maybe the first two, and then we take the next.
Yeah, of course, you've hit on a very important area, that yes, self-management by women does require legal access to commodities and to information. But as we've already begun to hear from our colleagues there are many ways in which access to information can be made available, especially now that we have, newer technologies, digital and other options to reach women. Mifepristone is registered in at least 86 countries. Misoprostol is available in almost all countries. Misoprostol is legally available for post-abortion care, even if there are restrictions for safe abortion care. And also we do have to understand that we tend to think in black and white, that it's illegal or legal. But in most countries of the world, safe abortion is possible for particular indications, especially when you're working in the humanitarian context, and rape is an indication that could be an entry point. It's also very important that although the initial reaction often is, this doesn't happen here, it's not our problem, it's a problem of other countries or other cultures, once you begin to explore the data with the community and with the people involved, it does become obvious that this is a problem there as well. Discussing the problem of unintended pregnancies, discussing the problem that women have, and you will find that ultimately people do accept that there is a problem to be addressed. So it's not easy, but it is certainly possible.
Thank you. Lucía, the question.
This is a very interesting, and thank you so much for bringing it up. I want to say that misoprostol and mifepristone have been in the essential medicines list of the WHO since 2015. It's been 10 years that we are, because we have decided politically that we are preventing people from accessing the benefits of scientific development. We are preventing people from accessing important medicines. So on behalf of my organization, our invitation is to think that legality is not the measure of possibility. And when we have unfair laws and we have people dying because of those unfair laws, we ourselves as an organization feel that we have a duty to act. And in the case of Poland, that is exactly what we have done, and I think I will touch upon that. One of our colleagues has been criminalized. She has been considered culpable of aiding and abetting an abortion, and as such is waiting for the appeal of her sentence, because in Poland, self-managing an abortion is not a crime, but providing support and providing information is, right? So I think it's really important to say that there are no, like, these are risks that we are taking, and the risk analysis that Najat was saying, that is the equation that we like to position ourselves. Not everybody can do it, and we absolutely understand. But I also want to highlight that I'm not Ukrainian and I'm not Polish, I'm Uruguayan, and I am from the countryside of Uruguay, and I have worked in Latin America quite a lot, and I have worked in partnership with the Mama Network, which is a network of activists in Africa also quite a lot. And there's going to be dissent, there's going to be resistance. Obviously, people have different emotional approaches to abortion, but like, to us is the commitment between what is fair and what is just and what is dignifying for the person and what is an outdated, at most outdated, and if not, very harmful legal framework. So I don't know if I answer your question, but I hope. I'm happy to chat further down the line.
Thank you. So we have 3 more questions. It's like this.
Maybe, sorry.
Yes, thank you very much. In fact, today I have heard a lot here on safe abortion. But I was touched when the moderator started saying abortion care services is shrouded in silence, which means even among you humanitarians and those in the medical field. I'm coming from northeastern Nigeria, the home of the Boko Haram crisis. Today I have heard a lot, but down there where I see, in fact, I work with several networks of the most vulnerable women, where we see daily, almost on daily basis, a child thrown on the street or on the gutter, sometimes half eaten by dogs and others. And then people asking me what they do with their pregnancies. I don't even know where to refer them to, because I have never heard, honestly, in the context I am operating, I have never heard of this safe abortion, and then how do you go about it? I'm bringing it because I'm seeing it as a necessity. So therefore, yes, you have researched a lot to come up with these several initiatives to aid this, but what have you done to popularize, to inform people and enlighten them? I can understand perhaps in the context I am coming, a religious setting where in fact what even necessitates abortion is sometimes a taboo to talk about. But then women coming telling me, Mama, this is a protracted complex situation. Girls and women are gang raped. They come to tell us, I don't even know who the father of the child I am carrying is. And then they engage in several unsafe abortions where many of them die. But what impact the issue I'm talking about is in a religious context in particular, where these gentlemen before have touched, where a child born outside wedlock is considered an illegitimate child. But then, in my little knowledge of the religion, there is a provision for abortion during a specific period of the pregnancy. And then in view of the complex situation that we are now living in, a conflict where women find themselves in a situation that they are not supposed to be, they are not protected, they are not catered for, and then find themselves pregnant. I think concerted advocacies, concerted outreaches, working with actors in the field to reach out with clear evidences of what we have been seeing and hearing, and then what the religion also has provision for, engaging with proactive Islamic scholars to back us up. I think we can go a long way to save the lives of these vulnerable young girls and women in conflict situations and then in fragile environments in our developing countries. Thank you very much.
Thank you. We're unfortunately running out of time. I would like to collect the other two questions I saw here and then have a quick answering round, and then we have to come to an end.
Thank you. Amanda Panella from Handicap International, also known as Humanity and Inclusion, depending on where you're coming from. So according to the WHO, we know that 16% of the population are people with disabilities, and women and girls with disabilities are among the most marginalized groups. I was wondering what kind of services you offer in order to get people with disabilities access to information and abortion care, especially people who may not be able to reach a clinic to begin with. Thank you.
Thank you. And there was another question here. Yeah.
Hello, thank you everyone, wonderful presentations. Just a point that I've noted throughout the discussions is there's a lot of focus on crisis related to conflict. And with the trend that is going on currently, climate change has similar impact on SRHR, very close to conflict. So what are the avenues, for example, through WHO, through IPAS, that you are advocating to ensure that SRHR, especially safe abortion care, is prioritized in response to climate crisis? My name is Hadija Saidi, working for Maternity Foundation based in Copenhagen. Thank you.
Thank you. So, yeah, who wants to answer or just start?
I just would like to come back to one of the first questions about your work with complex context and religious. Sometimes we have the perception that we cannot find allies in religions, but in other countries we work with imam for abortion, and there are sensibilization for girls. Imams that do the sensibilization for girls. So sometimes we need to talk openly about abortion, and for the risk we have this tool, but mostly, for example, for Médecins du Monde, we have a low profile strategy. I think sometimes it's better after you can do advocacy in the international scene, etc. But to invent the norm official, the traditional midwife, some kind of people, it's a good practice.
I think all of these are very important avenues where we need much more work in terms of difficult to reach areas and populations. I think one important other strategy is about integration. Like you mentioned, things don't happen in silos, and women's lives don't happen in silos. We're obviously discussing the topic here in particular today, but there's a whole range of needs, and that's exactly why we are talking about not taking this up as a siloed topic, but integrating it as part and parcel of MIS and part and parcel of a holistic response to women's needs in humanitarian crisis, and not singling it out as one issue. And I think that's also important in addressing the stigma, not leaving it behind and not making it the only issue either, but just treating it as one more need that needs to be met.
And if I could just jump in very quickly to the impassioned speaker from northern Nigeria, really important points. I would encourage you to actually contact our IPAS team in Nigeria, based in Abuja, but working all over the country in many different states, including the north, and connect with them to see how you can collaborate and connect with the work that's going on there. They've done a lot of work with many different organizations and with religious groups, etc., to work on this issue. It sounds like we need to be better, at getting the messages out. So, encourage you to do that. And then in terms of the climate question, it's a real challenge. I think, as Bela mentioned, integration is important. We are looking at, and there's a lot of discussion in the field about how we do better preparation, work toward resiliency with communities, with women, etc., and knowing that climate crises are coming more frequently, etc. And so, rather than being reactive, trying to be more proactive around the issue. But it's a really big challenge.
Thank you, Lucía. Do you want to?
Just very quickly to respond to the comments, because I think there's a lot to learn from people that are doing grassroots work. And I refer again, Mobilizing Activists for Medication Abortion is a network of more than 70 organizations across 27 countries in Africa that are doing a lot of work in sharing information safe abortion and also on self-managed abortion. And particularly to the colleague of Nigeria, in Nigeria, the protocols of use of the medications have been translated into Igbo, into Yoruba, they have been translated into Cameroon Pidgin, have been translated into a lot of local languages so people can access the information, very complex sometimes medical protocols into very easy to use guidelines. And those are things that are available freely on the website of the network. There are also helplines of people that can support. There are referral networks created with pharmacies to be able to access the medication. So there has been a lot of initiatives developed throughout the years in order to be able to palliate this crisis, because you're very right. We are talking about crisis as in war is a crisis, but the lack of access to contraception and lack of access to abortion is a crisis that exists throughout contexts, regions, etc. And with regards to the colleague on disability rights, one of the collectives that I work with very closely has translated the WHO guidelines, the executive summary of the WHO guidelines into Braille, has also translated the information on how to safely self-manage abortion with medication also into Braille. So trying to really make everything accessible, right, to meet people where they are. They work particularly with people with disabilities, mainstreaming disability all throughout the reproductive care package. So this is to say that, to encourage, to converse to the people that are doing really, really grassroots work, because they are extremely creative, extremely resourceful in bypassing a lot of the obstacles and the barriers that the system is setting up on people.
Thank you so much, all of you, and also for you, for your focus on this topic. And yes, there was a lot of information shared. Thank you for your insights, for your experience. And let me just say one last thing, because we've been talking about silencing a lot as well today, and we've been talking about how to talk and how to make information available as one of the big steps in order to come to a broader access to safe abortion. And we hope this could also be an impulse for you as humanitarian workers and NGOs in order to, yes, take this topic, find a way you can help, you can contribute to a broader access. And thank you a lot for your attention and for being here with us today.